Um, Obviously, I'm Kimberly Hendricks. Good morning. This is the Pebb board meeting for September 21st of 2021. I'd like to welcome you all. Again, I'm Kimberly Hendricks, the chair. Kate Nass, are you here? And Dana Harganani is excused. Kim Harmon, I see you. Good morning.
Yep, good morning.
Sean Parkman.
I'm here.
Good morning, Sean.
Good morning.
Mark Perlman, are you here this morning?
I am here.
Good morning, Mark.
Morning.
Saban Martin, good morning.
Good morning, I'm here.
Jeremy Vandehey. Senator Betsy Johnson. And Representative Andrea Salinas. Okay, so again, Kate Nass.
Hi, I think I figured out my microphone. I'm here. I was frantically, it was saying it couldn't recognize my microphone, and I was like, wait a minute, it's your microphone.
Good morning.
Yes.
We are glad you are here.
Sorry, really patient. I am here.
So that it's just Jeremy that we're not sure of. Okay.
This is Jeremy. I'm here. Just can't
good morning, Jeremy. Full house. I love it. I love it. And of course, Dana's excused. Okay, so we're going to get started. And the first item, Ali, did you want to speak quickly before we do the minutes?
Yeah, I just wanted to note that Kate Nass was at the last meeting, so we'll get that corrected on the minutes.
Perfect. Okay, so we have the minutes from August 17th of 2021. After review, do we have a motion to accept with the correction from Ali?
This is Siobhan. I'll make a motion that we accept the minutes as corrected.
This is Mark, second.
Thank you. Any question or concern about the minutes? Okay. Let's go ahead and I'll do a roll call. Kate? For the approval of the minutes? Thank you. Kim?
Yes, approve.
Thank you. Sean?
Approve.
Thank you. Mark, second. Mark?
Approve.
Siobhan, first.
Yes.
And Jeremy?
Yes.
Thank you. The minutes are approved as written with the correction that Kate was in the house at our meeting in August. Okay, I'd like to give Ali a moment to speak to us, and then we'll get started with COVID updates.
Thanks, Kimberly. We just had a brief change to the agenda. We want to go ahead and give our health equity subcommittee, they had just had their first meeting recently, and we're going to move that update into Michael's provider diversity update. So give him a little bit more time. He's sponsoring that meeting and can give an update on the exciting work that they're doing. And that is it, Kimberly.
So you didn't want to update on the extension of the incentive?
Oh, thanks for reminding me. So the vaccine incentive program, you might remember in June that the board delegated authority to board leadership and staff to manage a vaccine incentive program, and Pebb is extending the $100 vaccine incentive so it aligns with the governor's deadline of October 18th. What we'd like to do is get our members back in the doctor's office, receiving the care that's really been deferred, and believe is that increasing vaccinations are our pathway to get there. So we built up additional surplus this year due to this unfortunate deferral of care. And I think, you know, Mercer's talked about the long-term implications that has on our ability to meet the 3.4%. So, you know, we want to do whatever we can to to support our members getting vaccinated. And just a brief count, we currently have 31,367 employees who have received an incentive. That's about 60%. And there's at least 10% that have been vaccinated but have not requested an incentive yet. We also have 659 religious or medical exemptions, which is about 2% of the total. So we're going to be once again hitting getting communications out probably later today, and really hammer that home the next month and get as many people notified as possible. And that was it.
Thank you. And I just will say appreciate from Department of Corrections. It helps me to remind my staff that there is, there is an incentive out there to update the database. I think there's a lot of people that don't want to be tracked, maybe. I don't know. Anyway, but $100 is a nice little amount of money. All right.
I have a quick question on it. Ollie, is it going to be seamless, like anyone who's gotten the vaccine starting in early September? Because we had a date that it was ending in August, right? And so it'll just pick up anybody. There won't be a hiatus of like a few weeks where someone won't have qualified, correct?
That's right. The communications will pick up those people, and and basically, anybody that's been vaccinated at least one shot, you are eligible to submit for an incentive payment. So yeah, it will pick up those folks.
Great, thanks. It's great for extending that.
It is. So we are going to next have our COVID updates and vaccination strategies from our providers, or from sorry, I've lost my words. But I want to just remind my presenters that last meeting, Jeremy Van de Hey had asked if the carriers would bring back a greater focus on the strategies that they have employed to move the needle on the vaccinations from 70 to 80% and beyond. So hopefully the carriers updates will focus on that, and we'll go ahead and get started. And this month, first up is going to be Kaiser, Dr. Bachman, and we're going to get you started.
Thank you very much, Kim, and good morning to Pebb board members, staff, and consultants. Pleased to introduce you to Shannon Serber, who is my colleague. She's the senior administrator at our Eugene Chase Gardens office, and she's also our vaccine leader at our regional command center, and will be providing the specific information requested about our strategies to increase vaccination. Like we're seeing with the rest of the state, similar patterns we're seeing at Kaiser Permanente, and there is a lot of activity related to COVID. Similar to the state, we are at sort of peak capacity. We may have passed beyond the highest peak of the surge, but we are still at a very high rate in terms of diagnoses, utilization of the hospital, and our intensive care unit. Like we're seeing throughout the state and country, most of our hospitalizations are in unvaccinated people. In terms of Pebb testing essentially of Pebb members has doubled between July and August. In August, there was almost 2,900 Pebb members who had a PCR test with a positivity rate of 7.9%. That is somewhat less than our overall current positivity rate of 10.5%. Our lab has been working hard, and they have a new machine coming online in just a few weeks, and we're able to increase our test capacity for PCR testing from 2,000 a day to 3,500 per day, which will be very helpful for getting tests processed quickly related to school and work exposures as the pandemic continues. Our lab turnaround time has really been less than 24 hours, almost consistently, unless there's been some technology problems. In terms of Pebb members in the hospital, there's currently 10, and that's actually been a stable number since June. And currently, as of August, end of August, there was one ICU claim. Turning to vaccinations, good news. In Pebb employees, we're seeing increased vaccination rates through the month of August, actually a 10% increase from 77% to 85%. So that is nearing herd immunity levels. Unfortunately, Pebb employees don't live in isolation, so that doesn't count. And that's a better number than we're seeing with 74% of KP members have had one dose. So again, the governor's mandate as well as the Pebb incentive is having some benefit that we're seeing for Pebb employees. The current environment in care delivery is challenging, to be honest. We're working hard to care for our members. We're stretching our resources. Our beds are full. There's a high level of diversion throughout the city, which is a challenge for us to care for our members as they tend to be more scattered, and we're getting the opportunity to care for other patients from the community within our hospital. We have had the painful step of postponing non-emergent surgeries for the next few weeks. That's really awful news for individuals who are waiting for spine surgery or knee replacements or certain kinds of other surgeries that need to happen. These really aren't elective surgery. These are important surgeries, and they're being postponed, needing to save bed capacity for COVID cases. Our staff are stretched. It's really to be honest, I mean, we have care delivery operations which are ramping up to sort of near normal levels. We have flu immunizations coming online, which is fantastic, but does take a lot of staff. We have COVID swabbing staff needed for the surge. We're offering COVID vaccinations for third dose for immunocompromised members, and we're ramping up for the likely FDA recommendations for pediatric vaccination and boosters. All of this pushing our staff for lots of hours, and we are getting support from traveling staff, also support from retirees and other non-employees who were very nice to help us at the Oregon Convention Center and this for the mass vaccination clinics there, and we're asking them to come back to continue to help. I was asked to comment about monoclonal antibodies, and just the long view is compare that technology to vaccine technology. Boy, the vaccine wins, right? Vaccines are safer, less logistically complicated to deliver, less expensive to administer, and even importantly, more likely to prevent spread to others. I mean, so really the vaccines are a much better product to be pushing out there. For the monoclonal antibody, the number needed to treat to prevent one hospitalization is somewhere around 30, somewhat lower in people at highest risk. There's really been not a lot of use in the Portland metro area until recently, because of the logistics and complexity of giving the infusion to an infected patient and the nursing shortages, to be honest. So we've been using them for the highest risk individuals, sometimes within our facilities, and sometimes via home infusion, including via paramedic services where available. We are ramping up capacity to give monoclonal antibody infusions, and we aim to give about 40 daily, and are working on securing COVID safe spaces throughout our region to be able to do that. Our vaccination goal is herd immunity, so this continues to evolve. We thought herd immunity would be 65 to 70%, but with Delta, it's clear it probably needs to be more like 85% or more. So that it really is our goal, but clearly the goal for any individual is to get them vaccinated. So for any one person, the goal is to help that person work through the issues, answer their questions, tailor our information, and to get that patient that we see immunized. We are tracking through our dashboards rates of vaccination by location, by ethnicity and race, by age, and other factors. With that, I'll turn it over to Shannon to talk about some of the specific strategies that we're using to improve COVID vaccination rates.
And thanks, Dr. Bachman. Before I start, I see Sean, you've got your hand up. Did you want to go ahead and ask your question? I think you're still on mute.
Okay, let's try that again. Can you hear me all right?
We can.
Yep.
All right, great, thank you. Just a follow-up question on the monoclonal antibodies treatment. Is it true that there's a version of it now that doesn't need to be infused? Instead, it can be administered by a wider range of medical personnel to basically just a shot in the arm at this point?
Yeah, it's 4 shots in the arm and still requires the hour of monitoring afterwards. So there still is the anaphylactic risk. So it's not complete. Yes, it's easier. It doesn't require an IV setup to do it. But that's not really the entire logistic issue with it.
Okay, it still requires an hour follow-up. Okay.
All right. So I'm just going to piggyback a little bit on what Dr. Bachman said and share with you some of the specific and more recent vaccination efforts that we've been working on within KP Northwest. So we do have a vaccination command center that's been kind of up and down based on how much work there's been to do. It is currently activated, and I serve as the co-incident commander with Dr. Warshaw that reports up through our regional command center within KP Northwest. Some of the specific things that we've been doing, we have a vaccination care gap that fires in our electronic medical record. We counsel patients, regardless of which visit they come for, to ask if they're interested in getting a vaccination, and we have the ability to offer that to them in all of our medical office buildings as part of that visit if they're interested. We also have a kp.org message that goes out from the member's primary care physician to come in for a vaccination. And we have lots of continued communications around vaccine safety, efficacy, availability, and we're able to support that in multiple languages. We've also been working to vaccinate our homebound members, and that effort has been really successful. And then to address what we're anticipating upcoming boost approval, as well as flu, as well as continuing to offer COVID first dose, second dose, and for some of the vaccines, third dose. Starting September 8th, we'll be opening regional vaccination centers in each of our service area. They'll provide both flu and COVID vaccinations, including boosters once they're approved. And we're planning to have these up and running for about 10 weeks. It is an appointed model, so members can go and appoint through kp.org or call the call center and get an appointment in order for us to be able to best serve them and keep them out of our medical office buildings. We also know that one of our hard to reach populations is our BIPOC population. And so we continue our commitment to diversity, equity, inclusion in our vaccination process specifically. Our goal, obviously, is that we have no one left behind because of language, because of mobility, transportation issues. So our early strategy was really focused on community partnership clinics within our own facilities. But as hesitancy increased and volume decreased, we really had to pivot that focus. So I want to share with you just a couple of things we're doing. One is called, we're partnering with Project Access Now and providing some community vaccine events staffed by KP weekly at the Beaverton Resource Center in Portland. We've been doing that for the last 2 months, and it primarily serves the BIPOC community members. We also have a partnership with Medical Teams International, and they have mobile vaccination clinics that go to community events. They've conducted over 51 clinics and vaccinated over 1,000 hard to reach individuals. Over 50% of these were BIPOC. And then one of the newer partnerships we've been doing that we're excited about is a vaccine acceleration project. And this pairs dental care in rural communities with COVID vaccinations. So we just started this. It's just been in for a few weeks, and they've already done over 108 vaccines, most of which is in the BIPOC community as well. So those are some of our more recent efforts. And I don't know if you, if we do Q&A now, or we want to just pass the baton, or back to you, Dr. Bachman.
No, I think that's it. It's just interesting, one observation, when the emails went out from physicians through our secure email to members, how many emails I got. I must have about 20 emails that people had been vaccinated, usually at either smaller centers or out of state, just saying, boy, that's to let us know that our data wasn't accurate, which is kind of nice, because I think we may be underappreciating the number of people who have been vaccinated, and true vaccination numbers may be a bit higher than we're reporting.
Thank you
With that,
all so very much.
Turn it back to
And I
Kim.
don't see any hands up, so we're going to go ahead and go on to MODA, and we have Dr. Singh.
Hello, good morning. Thank you. Robin Singh from MODA. So, although nationally there are signs that this fourth wave is leveling off with reductions in cases in many states, here in Oregon it's too early to say if we've reached the peak in terms of numbers of cases. As you've been hearing, hospitalizations, ICU visits and deaths continue to rise. This, along with staffing constraints, is causing us to reach full bed capacity in many regions. Taking a look at the data for our Pebb membership for the pandemic to date, number of members have been tested, 6,247. Members with a COVID diagnosis positive, 641. ER visits to date, 89. Hospitalized, 33. Members in ICU, 15. And fatalities that we know of, 3. There's been a significant month-on-month increase for the last 3 months of this year, with August being the worst month to date during the pandemic. And then for August, we at 131 of that 641 have come just in that single month of August in terms of new diagnoses, 20 ER visits, 6 hospitalized, and 2 in ICU. This has led to 2021 generally having higher numbers across the board than 2020 did. Although diagnoses, ER visits, and hospitalizations are up, ICU admits are only up a little bit, and fatalities remain low for now, likely demonstrating the protective effect of vaccines. Overall, 69.2% of Pebb subscribers and dependents have had at least one vaccination, and 63.8% have had a complete series, defining that currently as a maximum of 2 doses at this stage. Breakdown by region of highest to lowest vaccination rates. This is for at least one vaccination. Portland Metro at 85.3%, Eugene at 79.1%, Salem 70.8%, the Oregon Coast 67.4%, Central Oregon 62.4%, Southern Oregon 57%, Eastern Oregon 52.8%. So across the state as a whole, we're seeing Eastern and Southern Oregon vaccination rates lower than the Valley and metro areas. Breakdown by age shows the highest group being 65 plus at 84.8%. And this is gradually decreasing to the lowest group being 12 to 15 years of age at 48.4%. There is essentially a direct linear correlation with each decrease in age range corresponding to a few percent decrease in vaccination rates. We're also analyzing our data for other characteristics to help inform targeted efforts to increase vaccination rates, for example, by zip code, by provider group, by ethnicity, amongst other data fields. Looking at the strategies to increase vaccination rates, so there's a wide range of factors contributing to vaccine hesitancy in parts of the state and amongst various specific groups, in addition to significant misinformation. Our role has been and continues to be to provide high levels of support to all our members, and in this case, focusing on our unvaccinated members with credible information that's timely and up to date, and a high degree of assistance in obtaining vaccinations, testing, and staying safe and healthy. So detailing our specific efforts, one big area is targeted communications to our members. So focusing on vaccine efficacy, availability, ease of access, and that they're at no cost. Providing detailed information about testing, effectiveness of masks, and other general preventative health measures. We're ensuring members are informed of their COVID-19 benefits and know where they can access information about these benefits. Our strategy in communications is to stay aligned with and support state and county efforts. ensuring our messaging is mindful and culturally aware based on the populations that are being targeted. Through our website and member portal, we lead members to trusted COVID-19 vaccine information, and we provide specific links to where you can receive vaccines and testing as well. Through our call center, MODA staff are inquiring about and encouraging vaccination for all members, providing assistance to unvaccinated members who are open to vaccination in terms of finding sites, scheduling their appointments, connecting them to care providers, addressing transportation, etc. as needed. We also work closely with providers to provide them with, for example, vaccine confidence workshops that have been delivered by community organizations. In some cases, we provided gap lists to certain sites and assistance in member outreach in some cases. We partner with public health officers, especially in Eastern Oregon, on joint efforts, utilizing our data increasingly to target relevant, scientific, actionable messaging to our members, focusing on vaccine eligibility, for example, the third dose, and who is eligible, and reaching out to those folks. Vaccine efficacy, focusing on the FDA approvals, vaccine and testing access. We're emphasizing the confidentiality of vaccination history, that your vaccination status is PHI, your neighbors, community don't need to know about whether you're vaccinated or not. Most significantly, our healthcare services teams are reaching out to high-risk members based on clinical criteria, providing them with additional support and coordination to ensure they have access to vaccines, testing, and medical care as needed. Although also those receiving care coordination, care navigation, complex case management, behavioral services, or health coaching are all being given information about vaccination. Essentially, whenever our team interacts with a member, it's currently part of our workflow and process. Since we know each member's vaccination status, we're then able to target resources and conversations to those most likely to benefit. We're not stopping. We know how important it is for people in the state of Oregon to get vaccinated, and we're determined to continue proactive efforts to provide support to every unvaccinated member. Thank you, and I'd like to hand over to Katie Sheeler from Pharmacy to discuss monoclonal antibodies. Thank you.
Thank you, Dr. Singh. Katie Sheeler, pharmacist with MODA, Senior Clinical Program Manager. I just wanted to touch specifically on the coverage of the monoclonal antibodies. We were asked to speak directly to how MODA is currently covering these treatments. So they are currently covered at 100% cost share. So members have zero out of pocket at this time for these treatments. We don't have any edits on it. Specifically, the nature of how quickly one must ascertain the treatment if they're post-exposure or if they've had a positive test and they're at high risk and they meet all the other criteria over 40 pounds, or excuse me, 40 kilograms, etc. I did want to mention back to Sean's question, Dr. Bachman addressed the hour that must be, the patient must be watched after the administration, but also wanted to say that for members who are utilizing these treatments for the treatment instead of post-exposure prophylaxis, the recommendation is for IV therapy. If that is not able to be ascertained quickly enough, then the sub-Q formulation can be utilized in that specific population. That IV is recommended there. And I just also want to mention this is our time to talk about flu vaccines, and we're taking this as a great opportunity to wrap COVID vaccines into that, because a lot of people don't know that you can give both the flu and COVID vaccine together. So all of our typical communication about flu is also including the COVID, just as another opportunity. I myself am so excited to take my children to get a flu shot and a COVID shot, hopefully by the end of this year. So I just want to, again, thank the Pebb board for your oversight and direction and support of the vaccines. That really, as Dr. Bachman said, is a preference is to prevent infection in our high risk as opposed to, treat. So I just appreciate you guys helping to encourage our community to take care of one another. And with that, I'll hand it back to you, Kimberly. Thank you.
Thank you so very much. It's so good to see you both. All right, on to Providence, and we have Helen on this morning.
Hi, good morning. I will actually do some quick introductions for the team. I'm Cash Spencer, and I am the manager of the self-funded line of business within Providence. And with us today to provide the COVID vaccination update, of course, is Helen Noonan-Harnsberger, who's our Vice President of PHP Pharmacy, and Jessica Nicolcha, who is a specialist on our clinical pharmacy team. With that, I'll turn it over to Helen.
Thank you.
Okay, good morning. I'll take a few minutes just to focus on the question on strategy for continuing to improve vaccination. And as is our practice, we will be sending to Kimberly and to Ollie a copy of our slide deck that we're speaking from, which is just an orderly way of presenting the information we have for you today, and just something you can look at and share with others as you would like to. Specifically with regard, what I'd like to do today is do the focus on the strategy, then go into the questions that you asked specifically related to the use of monoclonal antibodies. And as Cash mentioned, we have Jessica Nicolcha here to talk about our strategy in terms of getting information out in the communities. And we do have Dr. Tobias Push, who's an infectious disease physician, and our chairman of our P&T committee, who's here to also talk a little bit about the clinical use of these agents as it's sort of rolled out in the last few months, specifically within our Providence system. So with that, I'll get hopping into vaccination. Good news, over the past month since we last reported, there's been approximately an 8% increase in vaccination amongst Pebb members. Specifically, when we look at our Pebb Choice membership overall across all age eligible participants, the rate is 76.4%. So that would be age 12 and greater. The Pebb statewide is lagging behind, as you might expect. That is where we have the most rural counties and where we're seeing the most issues with vaccine hesitancy and refusal, and that's up to now 70.7%. As I look across the age band specifically, what I can see is that in the age 41 to 64 and above, as well as any age above that, we are hitting the 80% level for the Pebb population across both products that you have with Providence. But we are seeing a lag still in the 18 to 40-year-olds, 16 to 17, and 12 to 15. Specifically, the 18 to 40-year-old population is 60 and 66.5% respectively, while the age 12 to 15 is 51 to 57% vaccinated, depending on product. And the 16 to 17-year-old is 56 to 61%. Overall, we've seen good progress in the adolescent age range in the last couple of months, which is good news, and seems to be leading what I'm seeing in the statewide numbers. Across the various BIPOC communities, and specifically looking at COVID vaccination by race, of interest is that the Black, Hispanic, and Asian populations are significantly above our white population with regard to vaccination. The white population is at 74.7%, while Black population is at 77.8%, Hispanic at 79.4%, and the Asian population at 88.8%. So specifically, we are seeing the impact of the rural hesitancy, which is primarily in Eastern, Central, and Southern Oregon, and also many of the smaller communities, even in the Willamette Valley. So that's you know, that is where the focus is in terms of getting information to those communities, making sure that people are being met by those who they know and trust, and having conversations. One of the things we've done in the local community in the Tri-County area is a lot of door-to-door work in specific counties and zip codes, actually, that are lower. And that, I think, has really helped our overall increase in the Black and Hispanic populations, per se. So with that, I'm going to transition to the specific questions that you had with regard to monoclonal antibodies. And just to start with, yes, of course, we are covering those agents that are approved for emergency use authorization, those monoclonal antibodies. And there is currently no cost to the consumer per se for those agents. They are covered in full. And over the last few weeks, we have seen an increase in availability of these products. And I want to switch now to allow Dr. Push to give a brief presentation to address some of the questions that you presented to us to address today. So Dr. Push.
Good morning, Helen. Hope everybody can hear me. Excellent. Well, thanks for the invite and the introduction. So monoclonal antibodies. Well, it's been kind of an interesting story in Oregon specifically, with the EUA being first, put into action back in November already. There was really no uptake in Oregon, which in part was logistics in the Providence system because they're not easy to use. They require an infusion clinic type application. And at that time, there was really a lot of infection prevention concerns with bringing these patients into the infusion clinics. No vaccinations at that point were available. So the COVID pandemic then improved by spring, as you all know, and this really became again an issue for hospital capacity problems, where we had literally last month then to consider these agents more significantly again to reduce admission rates. So we, with the medical branch, based on the clinical trials and the risk factors that patients have, established an algorithm of how to utilize these agents. So we literally focus on the past medical history of individuals, assigned a scoring system, and if people had the same score, we would then provide the antibodies on a first-come, first-served basis. So the infusion clinic at Providence, Portland is now administering these agents, and we're in the neighborhood of 16 to 20 patients a day have been receiving these agents. That is not a whole lot, but if you think about the number needed to treat that was mentioned earlier as anywhere between 20 to 30, you would eventually have an impact and hopefully reducing our hospitalization rates, which has been critical. In a way, some people think about these agents a little more critical in the sense that, this is nothing that we should focus on. The focus is clearly still vaccination, but with vaccination rates lagging behind and hospitalization becoming such a problematic issue, they clearly have their role. The EUAs were clearly warranted. These agents are active and very effective if given early. We give them up to 10 days after symptom onset. They're much more effective if they're given immediately within really 3 days. The EUAs were based on 3 days after testing positive for COVID as most effective. They're truly the most effective if you truly don't even have any symptoms. So very recently, prophylaxis monoclonal antibody dosing was approved, and that showed a tremendous improvement in very congregated settings. So household members, prisons, nursing homes, anyone who has been exposed and had high-risk features, multiple comorbidities would really benefit from these. The administration was briefly mentioned as also possibly given as subcutaneous infusion or injection, and yes, that is possible. The EUAs for individuals who test positive, meaning they have COVID, mild or moderate COVID, is regards IV infusion, not sub-Q infusion. That has been sort of extrapolated, and many systems across the country have been using also subcutaneous route of administration. Within now this week, literally, you probably all have heard that there's been quite a shortage nationwide about these agents because the utilization has just absolutely skyrocketed from, I think it's been like 5 or 6 fold. And so the national distribution will now be quite limited, and as such, now we have to again think about how to utilize these agents with a really narrow focus, who's really the highest risk category of patients that it still makes sense to administer them. And we're literally talking about this right now. The kind of email cascade has been unstoppable in the last 48 hours about what we're going to do with this, because the supply is going to run out really quickly. And we don't have yet a solution of what we're going to do. But it's probably going to be a factor in between, really many comorbidities, 3 or more, plus a time focus, meaning if you've already been tested more than 5 days ago, that you won't be eligible for this. But, the details we have yet to sort out. But indeed, yes, we're offering them. We've been offering them for the last couple of weeks now. And that's the status in the Providence system.
More to come, I'm sure.
Yeah.
The world is gonna be dealing with this, aren't they?
Yeah, so thank you, Dr. Push, for joining us. We really appreciate you taking time out of your day to do that and sharing that information. So Jessica, I'm going to turn it over to you, because I know there were just a couple other questions that we were asked to address regarding network access. So I'll let you go ahead.
Thank you so much, Helen. I hope you can all hear me. And I will just be speaking very briefly to address those questions that Helen mentioned regarding network access. And the first thing I did want to bring up, Dr. Tobias Push actually did mention, so one of the questions was, what are some logistical challenges that we anticipate? And distribution is at the front of our mind right now. As Dr. Push mentioned, just last week, distribution did change. Previously, you could order these monoclonal antibodies from the manufacturer, and now the Human and Health Services, or HHS, will now provide allocations through the state rather than providers ordering directly from the distributor. So it's not exactly clear at this time how new clinics or provider can register to receive monoclonal antibody therapy. As Dr. Push mentioned, there is a shortage of this, and so it is more targeted towards the higher risk patients. So per that recent HHS announcement, the state health departments will be determining where the monoclonal antibody product goes in their jurisdiction. So we're actively monitoring this situation, as Dr. Push mentioned, and we are planning to update our provider network as soon as new information becomes available and we have a better idea on distribution of these very important agents. However, HHS has provided a national map that patients and providers can check for monoclonal antibody distribution. I did include a link in that presentation that Helen mentioned we have sent over. And if you do look at it, just like Helen mentioned, you can see that the areas that are in need of this therapy are more rural areas. So that's what we're focusing on, how to provide this therapy for some of the rural areas. However, we do know that we are at Providence able to refer patients who are eligible and reside in Southern Oregon to Asante for monoclonal antibody infusion therapy. And we do have various Providence infusion therapies as well throughout the state. But we did think it was important that that is one of our main logistical challenges that we face with this therapy. Thank you so much. I will be passing the presentation back to Helen just to briefly discuss and then finalize Providence's answers to these questions. Thank you.
Okay, so I think the key thing is that when I look at Eastern Oregon, there are 8 locations that are administering the monoclonal antibodies. There seems to still be no locations within Central Oregon, at least based on what's updated. We may need to check in with OHA in case they're aware of things that have spun up in the last few days. But I do think that access in the rural counties is a significant issue, but there are providers who are starting to administer. I think with that, I'm going to turn it back over to Board Chair Kimberly Hendricks, and I thank you guys for your attention, and we're open to any questions you might have.
Thank you all so very much. I don't see any hands up, so we're going to go ahead and go on to our next agenda item. And again, thank you so much, carriers, for answering our questions. So next up, we have Senate Bill 551, Pebb OAR Division 65. We're going to have a request to file a temporary rule. Request to file as a temporary rule and move into permanent rulemaking process.
Right. It's a lot to say. Good morning. Thanks so much for having me today. And I'm here joined with Glenn Bailey. I'm April Kelly. I'm the Pebb and OEB Rules Coordinator. And I'm going to be talking about attachment 2, which is, I love it, it's conveniently on your page, on your screen here. But if you're looking in your packets, it's on page 6. I'm just going to briefly talk about the process, and then I'll turn it over to Glenn. But this would be a new rule for Pebb. It's actually would be a new division 65-0001, and it's related to part-time faculty benefits. Senate Bill 551 came out of the 2021 legislative session, which now has prompted some rules, rule language for Pebb. And again, Glenn will talk about the bill and about the rule language here in a minute. But this rule language did go through a Rules Advisory Committee, or we call a RAC, if you work for state government, a few weeks ago with a stakeholder group and interested parties. And then our plan is to ask for your approval to file temporary and then to move into the permanent rulemaking process. And the reason for that we are asking, the reason that we are asking for approval to file temporary is that the effective date of the bill is October 1st. So we have been working with community colleges and universities to help them with implementation, and then part of implementation is rules. But unfortunately, the rulemaking process, it just didn't give us enough time. Another part of the process is once we do file rules temporary and then we file the notice and we go through that process, we will have a public comment period, which will be taking comments from the public. And then once we get those back and the public comment period closes, staff will convene, review any comments received. And then our plan is to bring these back to you all at the December board meeting and ask for approval to file permanent. So with that, I will hand it over to Glenn.
Yeah, I was just going to give a brief overview of Senate Bill 551 just to provide some context, and then I can go over the language in the bill or in the rules, or just answer questions, whichever would be preferred. First of all, Senate Bill 551 was passed in this most recent session. It's an attempt to address part-time faculty's lack of healthcare coverage by providing them access to same employee-only benefits as full-time faculty. Basically, to be eligible, you have to have worked at a 0.5 FTE for 3 of the previous 4 academic terms. Again, it provides equivalent health benefits for full-time faculty. That was interpreted as medical RX. It requires that part-time faculty select what's called a home institution, and that's basically would be a community college or public university where they're currently working, who would they established a process for determining eligibility. They would determine eligibility and monitor the eligibility of the individual, collect and pay premiums, and administer the benefits. The reimbursement for this program is 90-10 split, with 90% paid by the college or university and 10% by the individual. And the college and universities can be reimbursed quarterly for that 90% through the Higher Education Coordinating Commission, which was provided appropriations for this bill. Are there, and just to kind of tack onto what April was saying about the effective date, it is on or after October 1st. The enrollment will be starting October 1st, go through October, For the universities, the effective date for coverage will actually be 11/1 of this year. For the bill itself, because so much of the administration, the eligibility determination will be done at the college and university level, we really focused our bill, our rules, on just a general overview of who is eligible and who is not for this program. Basically, a 551 person eligible member would be a member determined by the college or university. A member, though, who is already eligible for part-time benefits through their college or university would not be eligible for the 551 program. And I was gonna, Sean, you had a question?
Yes, can you hear me?
Yes.
Okay. Does this cover dental and vision?
No, it was interpreted to be medical RX, and that was a question that came up, and we went to the Department of Justice on that. They said because the appropriations were for only medical and RX, as well as that underneath the HB 2557 program, which was part of that statute, it was only done for medical and RX. And then lastly, they left some of this interpretation up to the colleges and universities who felt that, for that for right now, it would just be medical RX.
Okay. Yeah, thanks for that. And largely this workforce would probably end up in Pebb as opposed to OEB for the most part, do you think?
That depends. They may go to the OEB plans if they're working at community colleges because they're less expensive. But you're right, they may end up at Pebb because of the slightly richer plans.
So is that up to the universities or the organizations?
That's up to the individual, actually. The individual and it depends on where they're working. If they're only working at community colleges, then they would have to go through OEB. If they're working, say, at a university and a community college, then they could choose the university as their home institution.
Got it. Okay, thank you.
As we've been pointed out, they are eligible for full-time medical pharmacy coverage. They may waive medical and pharmacy coverage, but they cannot opt out and receive a monetary incentive. The 551 members are not eligible for the HEM program. Persons, and we kind of discussed this, who are already eligible for Pebb OEB coverage as a subscriber or dependent are not eligible for 551. And then because of this, Pebb will reserve the right to audit and then retroactively terminate the 551 coverage if it's determined that the person has already been eligible for part-time coverage through their institution. If they miss the enrollment period, they can appeal to Pebb for enrollment. The coverage elected is effective for the entire plan year unless the eligible member is terminated by Pebb or the Oregon Institution of Public Education for failure to meet the eligibility or participation requirements. The bill requires that the universities and colleges do, at minimum, check their eligibility twice a year. So you may have cases where a person, because they're only hired for, say, 2 terms, would only be eligible for 6 months and then would be terminated by the home institution. Pebb will not credit deductibles out of pocket maximums for members who transfer from an OEB medical plan, and it's pretty much the sole responsibility of the home institution to determine eligibility for coverage, and then it is the sole responsibility of the part-time faculty member to submit all information necessary to the home institution. And then lastly, these people would be eligible for COBRA if they were terminated. Are there any questions, any items that folks had in regards to these rules?
So we are going to need to make a motion on this to have the board staff act on our behalf. So are there any questions? Because we definitely want to get any of our questions answered before we make a motion.
So I appreciate the clarification that folks are not eligible for the dental or vision through 551. Are they able to buy it on their own if they choose? Can they add it to their plan?
No, not at this time. That, from an administrative standpoint, would require a lot of work to add in. So that for this first year, that was not considered, no.
And Glenn, this is Ollie. I would just add, you know, this bill just literally passed a couple months ago, and as you've heard, it's kind of an administrative nightmare, trying to figure out all the systems and data transfers back and forth and eligibility criteria between multiple institutions with different payroll systems and also a reference to PERS eligibility. So really, we've tried to get this up and running and working with the universities and community colleges, you know, by open enrollment with OEB, which was last month, and then Pebb's, which is this coming month. And I think, you know, we're definitely going to be looking at changes as well, universities and community colleges. But I think for this first year, you know, we go by the letter of the law, which is, you know, what was in the bill, and try to get this implemented and get those people the benefits that they deserve.
So I have a couple more follow-up questions. The 1090 split that you mentioned, that's spelled out in law, not in rules. Is that correct?
That's spelled out in the law.
Okay. Okay. And can you remind me, anyone, can you remind me, we have part-time plans, like you know, anyway. What is the financial arrangement there? Can you remind me?
Yeah, it's really complicated actually. With there's a state part-time subsidy involved, you know, that's several $100s, and they buy into the part-time plans. It's the same contributions, but there is a significant part-time subsidy. But we can bring back some more information to go through that calculation. It gets really complex really quickly.
Oh, okay. Okay, I didn't mean to put you on the spot there.
Oh, no,
I was just trying to get a little bit of a ballpark of like how this compares to that.
Mm-hmm.
You know, it's like vastly different, less generous arrangement, or like when you kind of pencil out the dollars and cents, it's like it's sort of in the same zone.
Mm-hmm.
I just don't have a sense for that.
The universities are 3% and 5%, I believe. So 10%, you know, is more. The community colleges, I'm not sure. They're with OEB, and I'm sure they have a myriad of different collective bargaining agreements that they go by. But you know, they could be comparable to the 3 and 5, but I'm just not sure.
Okay. Okay, we can talk about that later.
Mm-hmm.
Go ahead, Mark. Sorry.
Well, I was just going to say, as somebody that's from higher ed, I think that this is a huge development, and I'm really pleased to see that these people who have been sort of caught in the cracks, even though they work a lot for the state, are finally being able to get coverage. And so, Kim, you said we needed a motion. I'm not exactly sure what the motion would be, other than Pebb will do what it takes to enact this. How's that?
So it's got to be a motion for us to file for temporary rule, correct?
Okay, then I'm going to move that we file for a temporary rule to get this done.
Thank you so much, Mark. Do I have a second?
I will second that.
Thank you, Siobhan. All right, and I'm going to do a roll call. Any questions or concerns?
Yeah, can I? I have a couple more questions just on.
Oh, no problem.
The process. So so I'm hearing you say that there was allocation for this. That the universities can access in order to cover these new people. Well, they're not new, but you know what I mean. To this new benefit for these people. So, but I also heard that you said that it's up to the universities to decide who is and who is not eligible. Is that correct?
Yes, it's written into the law that they will develop a process for determining eligibility, and then they will determine eligibility.
Okay. And so if it were to happen that someone feels like they were unfairly excluded, and they applied some kind of appeal or something, that would go through some kind of arbitration in the university system, not into Pebb's arbitration system. Is that correct?
Yeah, I mean, at this time, we have not offered Pebb or OEB as kind of an appeal or arbitrator for eligibility, because the eligibility is a responsibility underneath. So it would really, yes, be some type of process that the universities and community colleges would have to handle.
Okay, and we don't feel, I mean, that feels fairly obvious. We don't need to spell that out in rules at this time.
No, we don't, because we're not, in our rules, we really don't address eligibility.
Okay. Okay. Thank you.
I think, with the administrative complexity of this program, I think, it might be wise to come back to the board in 6 months with a report on how it's going and really, identify any issues with some of these kinds of things that you're raising, because you're right. I mean, it was really a kind of a strange process where we've been working for a couple of years actually trying to figure out how this would work on our end. But at the last minute, the bill actually changed the administrative side to the universities and community colleges. So they've been kind of scrambling, trying to figure it all out too.
Yeah,
Okay.
and I would just second what Ali said. We certainly will we're going to identify issues, and we'll come back, with any issues and what has been, certain things that have been done to address these issues. So, and just just a little more context is this. What you see here, the version of the bill that finally was passed was literally done at the end of the session. All through that process, the earlier versions of the bill that Pebb and OEB had provided fiscal impact and analysis on was to do this kind of 90-10 split, but do it through the current, what's called HB 2557 process, which is done through OEB, that allows part-time faculty who have certain number of PERS hours in the previous year to then self-pay for medical coverage through OEB. And so at the last minute, they really kind of the legislators switched it and put more of the emphasis on the universities and colleges in both in payment and administration.
Well, and if I could just add, Sean, you mentioned the university system. Of course, there isn't a university system. There are 7 individual state universities and then a whole bunch of community colleges. And they do have some shared administrative things with some of them, but I guess the Higher Education Coordinating Commission is the body that oversees all the state universities and community colleges. But I guess fortunately for us, this is the universities and community colleges' problem, not our problem. And presumably if someone thought they were eligible and wasn't getting eligible, there is some mechanism by which they could appeal that. But I don't think anybody really knows what it is yet.
Okay, any other questions? So I have a motion for us to, with Senate Bill 551, for us to request to file as temporary rule. And do I have a second?
Yes, I seconded. Yep.
Thank you. And I'm sorry if you already did that. I apologize. I was listening. These are really good questions. Okay, any other questions or concerns before I move to a vote? Okay. Kate Nass?
Yes, I'll vote yes.
Thank you. Kim Harmon?
Yes.
Thank you. Sean Parkman?
Approve.
Thank you. Mark Perlman, you're a first.
Yes.
Thank you. Saban, you're a second.
Yes.
Jeremy Vandehey?
Yes.
Thank you, sir. Okay. All right. Looks like, any opposed? I don't think so. Okay, it looks like that motion was approved. Thank you both so much for being here and presenting to us. And again,
thank you.
It looks like we're going to have follow-up dialogue on this one. It's going to be a lot of work for staff. Okay, so we're at 10:37. So I would like, and I'm sorry, Michael, please forgive me. Can we do a quick 10-minute? Can we stretch a little for 10 minutes, or do you have to be somewhere?
Nope, I'm fine. I'm fine. We can take. I think it'd be good to take a break.
Okay, I just think that that's smart because let's get us up moving for 10 minutes. We will be back at 10:47. And thank you, Michael. Thank you for
No problem.
letting us do that. Thank you. So Michael, we're adding 15 minutes to your presentation. Is that correct? Is that what Ali was saying? You're going to speak to the joint equity work group. Okay, perfect.
Yeah, I'm going to try to get through this as quickly as possible so that you have more time for the carriers to present, because that's, I think, who the board really wants to hear from. So I'm going to power through this very quickly, or as quickly as possible.
Thank you, Michael, but we appreciate you presenting. So
sure,
we'll honor your time too. So thank you.
And Kimberly, if I could just tee up Michael's presentation.
Absolutely.
And get started. Thank you.
Well, we're at 10:47, so I'm, I'm pretty accurate on the time. So let's go ahead and get started. Welcome back, everyone.
Well, thank you very much. And I just wanted to say a few things before we get started with Michael and the carriers. In prior years, we've asked our carriers about this time of year to prepare presentations for the board, focusing more on network adequacy and outlining any changes to their panels and ensuring our members had access to all provider types across the state. And I think we still want to do that this year, but we really wanted to expand our request to the carriers and really focus more heavily on provider diversity and data collection strategies and actions to eliminate disparities in care. Mercer, Michael will provide a detailed primer here. And I did want to recognize that giving our carriers 25 to 30 minutes each to cover their extensive work in these areas is probably not adequate, but we do look forward to hearing from them and the important work in their organizations. And I think we're all trying to advance this work forward. And so I'm really excited to hear today's presentations. And with that, Michael, please go ahead.
Great. Thanks, Ali. And I think actually Siobhan had asked the question for update on provider diversity because we first presented, actually the carriers presented on that last year. And so this is, if you would, kind of a follow-up. So you go to the next slide. So thanks, Siobhan, for the question, actually. So I'm going to try to go through this pretty quickly, but I know although OHA staff and I kind of live in the social determinants of health, health equity and all that, I realize that board members may not. So this is going to be a review for some. So social determinants of health have been defined by the World Health Organization as are conditions in which people are born, grow, live, work, and are responsible for most health inequities. And so this is from the Kaiser Family Foundation, and it shows economic stability, education, community and social context, health and healthcare, and neighborhood and environment. So we know that poverty has an impact on people's health status, educational level, access to education, being able to live in an environment in a neighborhood that is safe and free from violence, access to health and healthcare, and ultimately the neighborhood and environment, so things like transportation. And sometimes you may have heard the term living in a transportation desert or a food desert, meaning someone lives in an area that does not have access to reliable transportation or to comprehensive grocery store and only has convenience stores, which negatively impacts people's eating habits. So we have finally kind of recognized that social determinants of health has a huge impact on health status. Frankly, Medicare and Medicaid plans have been working on this for a longer period of time than commercially insured plans, but commercially insured plans like Pebb are really beginning to recognize that this is a huge issue even for a commercially insured population. I'm going to give more examples of this later. Next slide, please. I had a lot of caffeine, so I'm talking fast. So I don't want to get in trouble with Kimberly. Anyway, factors influencing health. So this is a great slide that just shows that there's a number of factors that are impacting health outcome. The physical environment, social and economic factors you can see on the left has the largest impact. Actual clinical care is only responsible for about 20%, and then healthy behaviors 30%. Also want to point out that individuals that are members of underserved or marginalized populations, so based on race, ethnicity, people with disabilities, sexual orientation, gender identity, have additional stressors in their life, living in an environment that may be toxic or unfriendly to them. And there's a phenomenon called weathering, which is a physiological process that accelerates aging and increases health vulnerability. So you can have two individuals with the same diagnosis and same general background, but an individual from an underserved population, frankly, is more at risk for more severe symptoms, signs and symptoms, and poorer health outcome. So just want to acknowledge that social determinants of health is an issue, and then that can be compounded by individuals who are from a particular underserved population. The next slide. So I run into, although I don't think this board is like that, but I run into many employers who, frankly, have had difficulties believing that social determinants of health impact their employees. I'll have employers say, well, we pay our people a lot of money, and we don't think that social determinants of health is really a big factor. And so there's actually just a very recent study from the Journal of Primary Care and Community Health that actually looked at thousands of commercially insured patients or members, if you would, and found that 27% of insured members live in a zip code where the median income is at or below 200% of the federal poverty level, and compared them to covered members living in wealthier zip codes. And they reported using more emergency room services, missing preventive care services, having higher rates of behavioral health, diabetes, obesity, and/or high-risk pregnancies. This actually sustains the idea that social determinants of health, where you live and work, does have an impact on your health status. And among those individuals reporting barriers to taking healthcare or medications, you can see what they identified are issues. Identified cost or insurance. So you might think, well, gee, they've got insurance. But if you have individuals that are in high deductible health plans, they may delay preventive service, well, not preventive services because that's $0 coverage, but chronic care medications, chronic care follow-up visits, and so forth. 26% identified family, school, or work responsibilities, and 4% identified travel or transportation. So I show this, and I'm going to show a couple of other slides in a minute, just to show to you that even in a commercially insured population, social determinants of health does impact a commercially insured population. Siobhan, did you have a question?
I just wanted to jump in because I really appreciate this slide. And I also think, we know that our members have really good health insurance through Pebb. And I also think that we can pay attention to who we're contracting with and looking at what the health insurers are doing for their population as well, the workers, because as you mentioned, Michael, an employer might say, well, we pay people well, but that isn't always true in the healthcare industry. And I do think that that's something we should also pay attention to in terms of when we put out our contracts, what it looks like in terms of what we expect from our providers providing good healthcare to our members. What does that look like for the folks that work for the healthcare institutions for those insurers?
Yeah, and Siobhan, even people that make a lot of money, like high-tech companies, they say, hey, our average pay is $100,000 or even $200,000. So why would they have these issues? Well, a couple things. One is they may be supporting a multi-generational household. They may be the sole breadwinner for half a dozen people. And so that large income, all of a sudden now, it's not as large as one thinks. And also, particularly in areas like San Francisco and New York, the cost of living is very high. And so although $100,000 might seem like a lot of money for someone living in a rural area, actually it may not be as much for people living in large urban areas. I would also just point out that one of the issues around social determinants of health is, remember I said where people live and work, that's impacts. So there's this phenomenon called redlining that happened in the early to mid 20th century, where it forced people from certain races and ethnicities to live only in certain zip codes. And although that was eliminated, I don't know, in the 60s, maybe starting in the 50s, people may choose to live in that community still, and they then may be living in an area that is a food desert or transportation desert or so forth. And so even though, let's say they're highly compensated, they have health insurance, Siobhan, but if they live because they choose to live in a community surrounded by folks from their community, they may encounter those same barriers. So I just don't be fooled by, gee, we pay them a lot of money and we have great benefits. They still are facing, and this study proves it, frankly. So I was glad to get this. So like I said, I didn't think that this board was going to push back, but I encounter that a lot. The next slide. So I want to just show this as an example of how to find social risk. So the Centers for Disease Control and Prevention has something called the Social Vulnerability Index. And so this is a way to identify, in this instance, CDC uses census data. Your carriers may use census data and other data to identify people who may be at social risk. They actually have a defined social vulnerability index as weakening a community's ability to prevent human suffering and financial loss. So it not only is from a healthcare perspective, but other perspectives as well. This only gives you an indicator of people who are at social risk. It doesn't tell you about an individual member who has a social need. Excuse me. So CDC took 15 factors, boiled them down to 4 categories. So socioeconomic status, household composition and disability, racial, ethnic, and language individuals, and housing type and transportation. And so those are the 4 buckets. 15 data points boiled down to 4 areas, which could be categorized, as social determinants of health. So again, this is just an example of how social risk can be identified, and your carriers may use this kind of data as well as other data to identify individuals at social risk. So you can go to the next slide, and I'll say colleagues at Mercer helped me put this together. So because I am not a I'm not a data person, so I just wanted to point this out. So the point of this is to also point out that Oregon has 6 counties considered high risk in the overall category. So you have those 4 areas and then overall category. And 16 counties are considered high risk in 1 or more of the themes. The cities most populated by Pebb's Oregon employees are in counties with at least 1 risk factor. Marion County holds the greatest population of Pebb members and also has the 2nd highest overall risk score. So again, if you had the notion like we're not impacted by social determinants of health, hopefully I'm convincing you that this is an issue that face your members and that your carrier partners and your healthcare providers can work on identifying and then addressing social determinants of health. So again, just to give you an idea that social determinants of health using this index, again, there are other indexes or other data points that you could use to identify people at risk. Go to the next slide. This is a little bit of a busy slide, but this is to show you on the right-hand side, it shows green is at highest risk, vulnerability, and lowest risk, green, orange, kind of purple and blue. And this is Marion County on the left. So I know it's a lot of data. Again, this is just to illustrate how social determinants of health, in this instance, using the Social Vulnerability Index from the Centers for Disease Control and Prevention, can identify people at social risk. And on the right-hand side, you see socioeconomic status, household composition, disability, race, ethnicity, and language, and then housing type and transportation. Housing type, by the way, includes people with disabilities. So again, this is just for illustrative purposes. The purpose here is to ensure that you understand that your members are at social risk. You can go to the next slide. At a population-based level, this is not looking at Pebb data specifically. This is the entire population. And so these are from my colleagues who are very much into data, which I'm into data as well. But this shows you the 4 categories that I mentioned, and then the overall category. Anything with a risk number 0.9 or above are members who live in those counties who are at high risk. So you can see the counties, and there are none with socioeconomic or looks like household composition disability, but there are people who are from underserved races and ethnicities, as well as languages spoken other than English, and then also the housing type and transportation. Remembering housing type is also factors in with people with disabilities. Okay, go to the next slide. So when I talk about social determinants of health, I think about this from 3 different perspectives. One is, what can you do as an employer? The second would be, what can your benefit vendors and health plans do? And then what can you do on a community-wide basis? And so the first one is making you aware. That's the very first bullet, that you believe that social determinants of health is an issue. identifying and helping folks navigate community-based organizations or CBOs, offering financial assistance, healthy foods in cafeteria, and a benefit plan design to support those with SDOH needs. Your vendors and health plan, so all your health plan partners, you want them to incorporate social determinants of health data, have community-based organizations that they can refer to, and then report on the identification and addressing of social determinants of health issues. The last bucket, admittedly, is maybe aspirational on my part, and this may be a consideration for forming some kind of collaborative arrangement with others, maybe other plan sponsors, particularly in areas with high social risk, to implement community-wide initiatives. On the Medicaid side, there's a lot of initiatives around the country that are trying to do that, connecting healthcare providers to community-based organizations and other stakeholders by county or by region. So it's just food for thought for you as a plan sponsor. Go to the next slide.
Hey, Michael, I just wanted to chime in here again, because I do think an additional bucket on there is, I mean, I'm repeating myself, but it is how are the carriers doing with their own employees? And I think that's worth us noting, because that's something that we can put into our RFP when we're, looking at all of our carriers. And that's just an important thing that we can do.
Thank you, Siobhan. Thank you for reminding me of that. That's a really good point. And as I'm going to channel my inner Sean and say, not just providers, but staff as well. Sean always reminds me of that. So
yes.
Just physicians and nurses, but also staff. So, housekeeping, dietary, and so forth, who probably are more the low-wage workers. Yep. There are three kind of categories of social determinants of health. This is the way I think about it, we think about it at Mercer. One is predicting and identifying people who are at social risk. In my experience with carriers and other benefit partners, is there's been a lot of focus on the predicting and identifying social risk. And although that's a great thing to do, and the social vulnerability index, which I showed you, is one way to do that. There's other ways to do that that I'll talk about today. So once you've identified risk, then what do you do about it? And what you do about it is navigating to community-based organizations, or CBO. So these are things like organizations in the community that help with housing or transportation, non-medical transportation, with food, access to food, healthy, nutritious foods, and so forth. And the last one is making sure that those individuals who have social risks stay connected to those community-based organizations, and that can be done through social workers, social care coordinators, and others. And in light of all of these buckets, I think the important thing is to ask for reporting from your carriers and your benefit vendor partners. So you get more information about your population, as opposed to me jabbering about the social vulnerability index, which is broad, to actually get information about your Pebb membership, about what kind of risks do they have, what kind of community organizations are they going to, and do they stay connected to those community-based organization services and resources. Go to the next slide. So this is from a survey that was done, Pulse of the Purchaser, the National Healthcare Purchasers Coalition Alliance. And so this just, you'll see that social determinants of health is the bottom one. So only 23% of the employers who responded to the survey said they were doing anything around social determinants of health. This is just to reiterate, this is very new in the employer space. Employers are just beginning to realize this is an important issue. You can see the other things up above. 57% of employers were saying they are working on people with multiple chronic conditions, the integration with physical health, looking at diversity within the organization, and that goes down from there. So, but social determinants of health is on the radar screen, if you would, of employers. Although 23% are doing something currently, 41% said that they're considering doing something in the next 12 to 24 months. So if your question is, what are other employers are doing? This is at least an example from one survey. This was not state employee benefit plans, but employers on the whole. So just to show you that this is an emerging important issue for employers. Go to the next slide. And some of you, I mean, all of us have the side of what we want to do the right thing for our members, but also what's the return on investment. So there is a study from the Commonwealth Fund that is kind of a meta-analysis. They drew together a bunch of different studies on what's the impact of addressing social determinants of health. Admittedly, the study primarily looked at Medicare and Medicaid plans, as well as what are called dually eligible beneficiaries, so people on Medicare and Medicaid. And so they did summarize the return on investment from those for addressing social determinants of health, housing, nutrition, transportation, home modification, care management, counseling, and other, just to show you that there is a financial impact as well as a human impact. Is there a comment? No? Okay.
It was just somebody who didn't have their mic on.
Oh, okay. Sure. So I think this is the last slide on social determinants of health. Any questions about, I know I ran through that really quickly, but I just wanted to give you the context of why this is important. And even with a commercially insured population, it's important. I think I've convinced you all maybe. Okay. Move on to the next slide. Sure. Next slide. So this is just a friendly reminder. We had our retreat last November. We reported out from the results of that in January, and we've been doing a lot of work around health equity. So just a friendly reminder, health disparities are unnecessary and unfair and avoidable differences in healthcare based on demographics. So this is, think of it this way, I would suggest to you. So rates of preventive screenings, people getting colorectal screenings, breast exams, prostate exams, and so forth, and also differences, unjust and unfair differences in rates of adherence to chronic care guidelines. So people with diabetes getting the care that they need, that we know is evidence-based care. So, annual eye exam, foot exam, and so forth. And so the idea with health disparities is use your existing quality metrics that your health plan partners present and take a look at that data through the lens of race, ethnicity, people with disabilities, sexual orientation, gender identity, whatever it is. It does require data to be able to look at it. So the reason that we want to address this is because these disparities do exist in the country as a whole and in your population. Go to the next slide. This is just a friendly reminder that the board adopted these assumptions, which is from the Oregon Health Authority's Health Equity Committee. The one I think that's most relevant to you that kind of hit home is number 4, which is that equity must be intentionally pursued as a strategy. It will not necessarily happen as a byproduct of other development efforts. So as I sometimes say, it doesn't just magically happen. It has to be very intentional with your eye on the ball, and you chose to do that when you adopted this as your framework of assumptions and values about health equity, which again is from the Health Equity Committee of the OHA. So there's alignment there as well. On the next slide. This is just another friendly reminder. This is the board adopted this definition of health equity, which you can read. So just basically wanting to achieve a system where everyone can reach their full health potential. I would also just mention that 20 years ago this year, the Institute of Medicine in their report called Crossing the Quality Chasm identified the 6 aims of a high quality, high functioning health system. And it was safe, timely, effective, efficient, equitable, and patient centered. So that also aligns with nationally where we see that equity is a really important component of achieving a high quality, high functioning healthcare system. So anyway, again, just a friendly reminder about what we're trying to achieve. Everyone reaching their full health potential and well-being. Next slide. This is also just a reminder, we talked about this about 13 months ago, I think August of last year, that patient and physician provider congruence is really important. We know from studies that when there is what's called patient and provider racial congruence, where the race of the patient matches the provider, that there's almost always better member experience and can be better clinical outcomes. This is also true for patient provider gender concordance. And I think what's important to point out here is providing information about the demographics of providers to members So whether it's race, ethnicity, gender, languages spoken, or whatever, really, I think demonstrates that you are trying to meet the needs and the preferences and the goals of each one of your members, regardless of their demographics. So it's a really important aspect of enhancing the member experience and their ability to pick a provider of their choosing. You on the next slide?
Well, and I think, Michael, it also shows that we're listening to our members.
Yes.
Because they have spoken very loudly about their concerns and trying to find that connection to get truly good results for a visit with their provider.
Absolutely, Kimberly. Thank you. Yep. Data collection is critical to achieving health equity, and I have identified it from on members and then as well as providers and practitioners. In addition to demographics, it's important to, in order to be inclusive, being able to have multiple access channels. So this also identifies the needs for people with vision loss, hearing loss, limited English proficiency. Another one that I've just come across is color blindness, be able to communicate in a way that's accessible for people who may have challenges with color blindness and not being able to read materials. There's demographics of providers and practitioners, but the other aspect is the competency. So for example, I was in a open enrollment session focusing on the LGBTQ population for a particular employer, and a medical director from a health plan got up and spoke, and he said, you know, I'm an openly gay man and a physician, but I'm not competent to treat transgender patients. That requires a very specific skill set. So even though demographically I'm a member of the LGBTQ community, the competency in working with someone who's transgender and who's going through a transitioning process requires a different provider. So just because my demographics are in the LGBTQ community doesn't mean that I have that expertise with trans patients particularly. So this is also a journey with employers and health plans to get this kind of data, not a small feat to do this. Usually employers are starting with race and ethnicity because that typically is collected at the time someone's hired. So you have that somewhere in an HR system. The other data points like sexual orientation and gender identity, which are maybe more sensitive, or disability status or veteran status, likely will come later. Some large employers like Boeing earlier this year announced that they were doing voluntary self-identification of sexual orientation and gender identity for a variety of purposes, not for healthcare specifically. And so it's just a thought in terms of data is a critical part of this journey. At some point, we can talk about how do we gather more data for your members in order to be able to, again, identify more health disparities to ignite more health equity initiatives. Go to the next slide. Okay. And those are just some resources for you. Let me just quickly talk too about what we're doing around health equity really quickly. One is that I've been working a lot with Brian Olson and Teresa Cross, so thanks to them for all of their work on this project. We could not have done it without their contributions and input and time. And we have developed a health equity screening tool based on your strategies and guiding principles from your retreat. We put through 2 topics. One is healthy productive meetings. The other one is the health engagement model. We're going to be asking for, we also have formed this health equity work group. Sean and Siobhan from Pebb are your representatives. We have 2 representatives from OEB, so this is a joint Pebb and OEB health equity work group. We'll be asking for 2 more topics from both Pebb and OEB to put through this health equity screening tool. And what it shows us is what's the potential impact of those policies and operational decisions, was the phrase from the board, your board meeting, that you wanted to look at from a health equity lens, not just a financial lens, but a health equity lens. And so we've done that work. We also will be launching a diversity, equity, and inclusion benefit vendor assessment process. So we'll be looking at DEI in your benefit partners. I've done this now for probably 36 benefit partners around the country. This launched about a year ago that we've been doing, and so we'll be looking at that. And the idea here is a discovery process. It's not a gotcha. It's really to find out where are you at today and where are some opportunities for improvement. So that's excuse me, that's also in the works. In addition to the health equity screening tool, we have presented this on several occasions to PMAC and the Worksite Wellness Coordinating Council as well to get their input, so we get the voice of the members as well to the tool and to the screening process. And so that's kind of in summary where we're at with health equity. More to follow. We'll have a report out likely in December on the DEI benefit vendor assessment. So more to come. Lots of work on this topic. And I don't know whether Brian or Ollie, you want to add anything more to that.
I think you've hit the high points, Michael. This is Brian. Thank you.
Okay, sure.
Thank you so much, Michael. Ali, I just have one question. So when we are looking at like updating our databases or our kind of our member bases, the portal, that all the information, are we looking at trying to gather these demographics? Do we keep those on our radar? I figured we did, but.
Yeah, I mean, you know, we're actually in the middle of a system replacement project with OWEB, and the system will be built with RealD data as kind of, you know, part of its core functionality, and you know, and I think everybody's trying to move in that direction as quickly as possible, and definitely, you know, we have two antiquated systems, you know, that gather some data, but not at the level that we will in the future. So, so yeah, we are getting there, but it's going to be at least a couple years away.
Okay, thank you. Mm-hmm. All right, so now we are going to go into our provider diversity and so the provider update. And first up is Kaiser Permanente.
Great. Thank you very much, Kim, and thank you to the board and the staff, and to Michael and his team for a really fantastic, interesting, important presentation. We are fully on board. The issues that you highlight are part and parcel to our work and our mission, and it's a journey, and the journey is an even more challenging journey with the pandemic and the other stresses facing the healthcare environment today, but has highlighted the importance of this work. I have two excellent leaders in the field with Kaiser Permanente, which I will introduce. And before I forget, we've also, because we knew we had way more to talk about than we had time today, we actually have a pretty thick document that kind of goes through some of what our strategies are and our implementation plan in more detail. That's available, that will be sent along to the staff and board later today. So our speakers today include Dr. Ruth Chang. She is the Chief People Officer at Northwest Permanente and the Vice President for People Operations. She's been an advocate for these issues in our medical group in the context of taking care of our patients and in her own practice and in the broader community. Our second speaker today is Nicole Friedman, who is Senior Director of Social Health and Community Engagement. Actually, Nicole joined Kaiser Permanente probably around 10 years ago. She can tell you that. And she was actually the first navigator, and the first office she worked in was my office at Interstate. And I can remember walking into her cubicle and say, what's a navigator and how are you going to help my patients? So she survived that test and has gone on and has had several increased levels of responsibility and is now really developing our tools and our strategy related to social health. With that, I will turn it over to both Ruth and Nicole. For next slide, please.
Yeah, thanks so much, Keith. And thank you again, Michael, for that excellent presentation that sets the context around why social determinants of health and the health equity issues are so important. So thank you, Kimberly, for the invitation. And we'll go ahead to move to the next slide. So I think really I'll be speaking about provider diversity this morning, but I think really the context of why we are valuing provider diversity is ultimately it's for us to best deliver on health equity. So how do we use provider diversity and, as Michael already mentioned, that racial and language concordance to systematically reduce healthcare disparities, create a more inclusive care environment where every patient feels like they belong and feel welcome, and then ultimately to ensure that we have effective communication with patients in every interaction. And in that effective communication space, not only are we utilizing the language skills of our qualified bilingual physicians and staff, but we're also thinking about how do we best leverage technology, so such as video interpreters and translation services to best communicate with patients regardless of what language spoken or what physical abilities that they have. So on the next slide, we'll talk a bit about what our current state is and our recruitment strategies to really continue to increase our provider diversity. Right now, Kaiser Permanente, we do have a diverse workforce, and we know we have continued opportunity to be as diverse, if not more diverse, than the membership we serve. In all of Kaiser Permanente Northwest, 80% of our staff is female, over 50% of our physicians are female, and overall 26% of our staff identify as a minority. And again, our ultimate goal and why we were wanting to create that provider diversity is to better serve our communities. So let me talk a little bit more about recruitment strategies in that in the medical group of which I'm the Chief People Officer in Northwest Permanente, we have laid out a very clear 3-year plan on how we're going to increase our provider diversity. And number one, back to Michael's point, is we've got to start measuring. You can't move what you can't measure. And the very first thing we did in thinking about our diversity strategy was to create dashboards and to see how we're doing. So now we carefully track who are the candidates we're attracting in recruiting, who's getting offers, and who do we ultimately hire. So we report this on a quarterly basis and track, and just to really see how successful are we in our sourcing strategies to increase reaching a broader, more diverse audience for who's we're advertising to. And then lastly, who are the candidates that we are bringing in? So with the tracking, what we also see is that we are needing to build good relationships with the pipeline, so help develop the pipeline, but also develop relationships so that we can intentionally recruit from our African American and Latinx and Indigenous physicians and clinicians. We've identified that those are the minorities that we have the opportunity to bring into our medical group. So intentionally, we're reaching out to the historically Black colleges, university, and medical schools, and also medical schools in parts of the country that have a higher Latinx and Indigenous population, such as California, Oklahoma, and Texas. That's been part of our recruiting strategy. This past year, despite the pandemic, we've also had our recruiters and physicians of color attend the National Medical Association, so that is the Black Medical Association, as well as the National Hispanic Medical Association conferences, specifically to recruit more diverse workforce. Now, I think when I mentioned we're recruiting for diversity, I think one of the other issues, what we see is we also have an opportunity to develop the pipeline and really develop pipeline locally. I think the gap in what we see between our membership and our actual physicians show that we can systematically invest in our communities of color locally so that one day they can become our providers. So to that, for our pipeline programs, we start in middle school because we figure that's not too early. If we can capture the hearts, imaginations, and the possibility thinking of our middle school students, that's when we want to start nurturing them and encouraging them to pursue a career in medicine. So we have partnerships with 2 local schools that have a higher percentage of underrepresented minorities. And then we want to show them and their parents that a career in medicine is possible. Other programs in our pipeline, we have paid summer internships for high school and college students, and we intentionally recruit in our local high schools as well as our local community colleges to ensure we have a diverse participation. And then through the local medical school, Oregon Health Science University, we offer a mentoring program to their students who belong in a diversity interest group. So those are some examples of all of the pipeline investments that we've made locally. Nationally, Kaiser Permanente also put a lot of resources behind these stated goals, we opened up the Bernard J. Tyson School of Medicine and matriculated the first class. So the class of 2024, I'm proud to say, has started their medical school training, and 56% of those students are Asian, Pacific Islander, Black, or Latinx. 36% come from social economic disadvantaged backgrounds, and 30% identify as LGBTQ. So that's incredible diversity of that incoming medical school class, and we're really excited to welcome them as future colleagues. And I think for the other key piece is, as we recruit and bring in a more diverse workforce, we also want to make sure we retain that workforce and continue to create that culturally responsive and inclusive environment. So to that point, we offer a lot of ongoing workplace trainings for both our leaders, managers, and our core staff and clinicians. One program I want to highlight for you is a program called Belong at KP. This is a national rollout across all Kaiser Permanente markets. And our goal is for everyone to complete this training. The focus of the training is to look at how do we identify and counteract unconscious bias. How do we create a more respectful environment for everyone where we can hear everyone's voice, and how do we best be allies to each other? Then the second part of the training will be specifically on how to dismantle racism. So this is a multi-year effort that we are currently promoting, and we're really excited to see the fruits of our labor. So on the next slide, here's some data to share with you. This is our current provider diversity for Kpnw. And as you can see, we do have a fairly diverse workforce, but we also have opportunities. And as I already called out, we definitely are intentionally recruiting for Black and Latinx clinicians and physicians. So comparing this to the Pebb ethnicity breakdown data that we received from you, your membership makeup is 72% white, 7% Asian, about 11% Latinx, and 4% African American. So as I previously stated, our goal is to be just as diverse, if not diverse, in the membership we serve. So we know we have work to do, specifically in the Latinx and African American provider space. But I just outlined to you all the strategies that we're pursuing. Another question that does come up is whether our doctors are accepting new patients. And the short answer is yes. For all of our primary care medical office buildings, we ensure that we have physicians accepting patients at all times. And then even for our well-established clinicians, we know that there's some turnover every year during open enrollment. So during open enrollment season, we basically are open to new patients across the board, with very few exceptions. So our goal is to be as welcoming as possible to all our new members. On the next slide, to facilitate helping patients find a physician of their choice, we do have the search function already up on our kp.org website. And as you can see, once you're looking for a physician that you can search by gender and language, we also provide the bios, photos, and other culturally specific care information within the bios of all of our providers. So I know this is especially important in the mental health space. And for mental health, the team has been very, very committed to culturally competent care. I would say all of our specialties are committed to this, but mental health has taken additional steps to ensure that they've got training for all of their providers and staff. They're periodically assessing the needs of the membership as a whole and continuing to develop any of the cultural competence measurement tools in the mental health space, as well as sharing best practices across all of our Kaiser Permanente markets, which have fairly different membership demographic makeup. So I think those are all the ways that we are ensuring that we're providing the best care possible. Now, I would say one potential silver lining of this pandemic is the wide adoption of telehealth. And we've been able to use that to our advantage to better take care of patients as well. In the past, when we were focused on face-to-face visits,
it may be difficult for a patient in Portland to travel to Salem or vice versa to see a provider of their choice. But now that we have widespread adoption of telehealth, it's much easier to connect the two. So that's also been working to our advantage to connect members and providers based on racial and language concordance. Next slide. We are also thinking very carefully in mental health on how to make the best match for our members. And so sometimes we will get specific requests for a type of provider, whether it's a specific race, age, gender, number of years of experience. And we want to honor all of those requests. So when we get those requests, first we look within our Kaiser Permanente internal resources. And if we're unable to find a good match for the patient, then we would refer the member to an outside network. Also recognizing that when we have open enrollment and we're welcoming new members, sometimes they may already have an established relationship with a mental health provider. And we have a clear process too, to assess this transition of care for those members. So we undergo a utilization review, and first is check to see who the outside provider is and what type of care they're providing. And then we'll conduct a needs assessment and look and see what internal resources we have on the mental health and behavioral health side. If we are able to meet the needs within our KP providers, we still issue the new member transition sessions. Knowing that we don't want to disrupt any ongoing care, we do want to have a thoughtful transition of care plan for the new members. However, if we're not able to meet the needs of the member and it's determined it's best that they continue their ongoing relationship, we will issue spot contracts to be able to bring that mental health provider into our network. So that is our process. And ultimately in the future is that we continue to track all of our numbers. So we're building out a population health dashboard to evaluate care gaps and needs. And we're continuing to update our mental health provider biographies. So as I mentioned, pictures, culturally specific care, language is spoken. And to date, we've already have over 50% of those biographies updated this year. We will also be making sure our addiction medicine department update their biographies before the end of the year as well. And then ultimately, as we continue to have a robust external referral network, we want to gather that information of our referral providers. So ultimately, we can make the best match for our members to those providers. And then lastly is as we are intaking, so as members are reaching out and seeking care, we are proactively asking them if there's any culturally specific care needs that they would want to make sure that is considered when we're matching them with a provider. So that, in a nutshell, is our strategy and how we're taking care of our patients and why provider diversity is one of our top priorities in the people space. So with that, I'm going to pass this over to my colleague, Nicole, to talk more about our social health strategy. So Nicole?
Thank you.
Thank you. Thanks, Dr. Chang. And I'm very happy to know, Dr. Bachman, that I passed the test. I think that might be my hardest test of my career. We can go to the next slide, please. So I'm here to talk about our social health strategy at Kaiser Permanente. And first and foremost, I really want to highlight that our social health is not a separate, standalone initiative, strategy, or thing. It is fully integrated into how we think about total health for our members and communities we serve. It is part of their physical health, their mental health, and the third critical pillar, social health. And when we think about social health in Kaiser Permanente, we think about social health for our communities. So that's our work in building capacity, grant making, our community partnerships. A great example of that is the millions of dollars we've given in the past couple of years to support housing efforts along with other health systems. And we also have to think about a social health practice for our members. So that is a new and emerging field for KP, where we think about, how are we identifying unmet social needs within our membership? How are we addressing those at the individual and population level? And how are we creating more synergy between the work that we're doing in our communities and the social barriers to care our members are facing every day? And there are 4 critical components to our social health strategy. We believe these 4 components are the most impactful based on the evidence for improving health outcomes, making care more affordable, improving the quality of care, and also reducing health disparities. And those 4 components are food security, so making sure our members and the communities we serve have access to nutritious food, making sure people have a safe place to live and are housed, financial well-being, making sure there's never a barrier to paying for a medication or getting a certain treatment, and transportation, making sure people have the means to get to their needed appointments, but also the means to do things for activities of daily living that we know contribute to health, such as going to the grocery store. So for this presentation, I'm going to dive more deeply into the social health practice for our members and what that means. So if we could go to the next slide, please. Okay. So when we think about our social health practice, we think about 3 key components. First, how well are we identifying unmet social needs? And I know Michael really teed this up well for us in the last presentation. After we identify needs, how are we connecting patients to the needed resources, patients and community members? So we don't want to screen for screening's sake. We want to screen and then have a solution or a resource. And then support and follow up. How are we closing the loop to make sure that that food box we gave a patient or that referral to a transportation resource met their need and reduced their barrier to their healthcare? So going first and going a little bit deeper on the identified component. At Kaiser Permanente in Northwest, but also across our entire enterprise, the 8 states and 12 million members, we have deployed a universal screening tool where we have standardized evidence-based screening around those 4 key components: food, housing, transport, and financial well-being. This screening tool is fully embedded in our electronic medical record, or EPIC, and we have a goal for our entire enterprise to screen 70% of our members by 2024. We've started that work in the Northwest. We're screening every patient as part of a primary care visit. We're screening every patient who has an acute visit to the emergency room or who is hospitalized as part of their assessment. We're screening pediatrics and new moms and OB. And we are working on workflows to digitize this, meaning allowing more self-service screening tools so that patients can self-screen, and we rely less on human resources to do that. And we'll have a huge digital self-screening pilot. Northwest will be the first, launching here in a few weeks, and we're really excited about that. After we screen, we know that we need to connect members to needed resources. So we have various partnerships, strategies, and interventions around those 4 core areas: housing, food, transportation, and finance, to make sure that once we identify a member's need, we're able to connect them to services. So the first one I want to talk about is our Thrive Local or Connect Oregon work. And this is a partnership with Unite Us, which is a national to scale platform. In Oregon, we have over 3,000 community organizations, social service agencies on this network, and over 400 of them are what we call in-network, meaning a provider can make a referral through our electronic medical record to one of these community organizations and get a closed loop. They can find out in near real time whether or not that agency is able to serve that patient. We have served over 1,500, we have closed loop referrals on over 1,500 patients served to date. We've shared thousands and thousands of resources with our patients, I think over 17,000 here in the Northwest. And what's really exciting is this tool is now available on our kp.org. So a patient can sign into their kp.org account, and just like they could look up, resources for tobacco cessation or make an appointment or email their doctor, they can now go on to Thrive Local and search for needed resources in the social service space. And we'll track that data to see what are our members looking for, who are they using, and what are they needing. So it's both a self-service strategy, but also a way to build a network of social services, knowing that Kaiser Permanente is not a social service provider. We need to partner with them. The second key intervention area is in our housing space. So we have a lot of exciting work happening around housing. One I really want to touch on is in November, we are going to be enrolling patients in what we call a med legal partnership. So this is a nationally proven evidence-based model that reduces health harming housing issues. So patients being evicted, patients who need extra support working with their landlord, et cetera. And we know that patients who are housed have much better clinical outcomes. They also spend less nights in the hospital. This work will start and will focus on patients in the North and Northeast Portland area. We're also taking an equity lens, focusing on our Black population who is more likely to be at risk of houselessness in Northeast Portland. And our goal for that is that we can reduce homelessness, reduce risk of eviction, keep people housed, and by doing that, we improve their health outcomes, particularly around mental health. We also have a great partnership, over $10 million grant, in looking at creating a pipeline so that health systems and government agencies can better identify houseless individuals, work together, and get them housed. So we're developing many workflows between hospital to housing, recuperative care facilities to housing, children who are aging out of foster care to housing services as part of a much broader housing strategy. The other area we're focused on is Food for Life. So we have a great pilot happening right now at our Sunnyside and Westside medical hospitals, where we are giving patients 1 month's worth of medically tailored meals provided by Meals on Wheels people. We've enrolled almost 500 patients into this study, and they have to have a specific chronic condition. That's the only eligibility criteria, and we're evaluating the efficacy of this program to see, by providing medically nutritious meals, did the patient have better clinical outcomes, and did we reduce readmissions in this population? If that's successful, we'll spread this much more broadly, and this is both a local and national initiative. We've also are partnering with many organizations, strategic organizations that can support the needs of our members. One I want to call out is our resource access centers. This is a partnership with Impact Northwest, a very large social service agency, where we have resource desks. They're virtual right now because of COVID, but typically in person, where any patient, member, non-member, community participant can walk into a Kaiser Permanente facility and speak to a resource expert about needed resources that they have. There's also a phone line they can call. And we serve about 100 patients a week with this service. And then moving to support and follow-up, we are also really thinking about not only how do we connect patients to resources, but how do we create more of a care management approach, a population health approach, as we're getting more and more data on our patients' social vulnerability or social needs. We could now start thinking about, who are our patients who have diabetes, but also maybe experiencing food insecurity. And that's really going to change our intervention approach. So we're building out infrastructure, resources, and staff to be able to respond to the unmet needs of our members. And a great example I want to call out is we're building out a very robust community health worker strategy at Kaiser Permanente. We've actually, and these are community health workers who will work with patients who have, I would say, more complex social issues than warrant just resource information, but they need someone to work with them over a longer period of time to get them connected to the right resources, both internally, but also externally. And with this pilot that we've been doing with community health workers, I'm pleased to say that we've done a randomized controlled trial, which is probably the most rigorous study you can do. We've enrolled almost 1,000 patients to date in this trial. And our first analysis shows that the patients that went through this program had a 50% reduction in hospital days, which equated to $82 per member per month in return on investment after the cost of the program. These patients were also more sticky to primary care, so they're using the emergency room less, they're using primary care services more. And another thing that we really focused on, again, taking an equity lens, was we hired community health workers who are demographic mirrors of the community they serve. So 80% of our staff are non-white. staff, and we were able to enroll a higher cohort of communities of color, Latinx, Black, et cetera, into this model. So we're also looking at showing how this work not only addresses social needs, but how are we addressing some of the health equity gaps as well. And then the last thing I want to call out before we move on, I see a hand up, is that we're taking all of this data and we're putting into our risk segmentation models so that we can make sure we're aligning the right intervention, the right level of intervention, and the right resource to the right patient need. So it's really helping us reimagine how we think about predictive modeling, predictive analytics, and what risks categories our patients fall into now that we have an influx of social data.
Okay, so we do have a question and we're out of time, so I'm going to let Sean ask his question. And I think behind the scenes, we're moving a provider to another meeting because we're totally, we're good. But Sean's got a question.
Sean, yes.
Thank you. So this is really impressive, and I'm impressed in particular with all these partnerships. My question is, thinking about houseless individuals, socially complex individuals, is it part of the plan, or have you considered as one of the partners being other healthcare provider, other medical systems, being that one of the challenges is the rotation between the different medical communities? It's not like they're going to stay. I mean, some of them may end up staying as a Kaiser member, but it's kind of like the way our system is built, not just in Oregon, but everywhere. It's like once they're not one of our members, it's like they don't exist. And because it's now someone else's problem. And so I'm wondering, is some of this partnership and connection, or the thought about it in the future, is to partnership with some of the other medical systems so that if there is a transition between the different different groups, that there's some continuity of this kind of effort?
Yeah, that's a great question. To answer briefly, Kaiser Permanente has been a catalyst in the Connect Oregon Community Information Exchange work, which addresses just that, Sean. So once we get consent, which there's a whole consent process so that patients' rights and privacy are protected. Once they actually have a referral in the Connect Oregon platform, they kind of become insurance blind, so that there is continuity of care in the social service landscape, so that if there's churn or if people switch a insurance carrier, we're still able to move forward with connecting them to those social service providers. They're essentially in this network of social service agencies.
Thank you. Okay, so Ollie, you're going to need to tell me what we were able to move around. Am I going to do, is Moda going to go and we're going to run past the 12:05 time and have people stay a little longer, or what?
Yeah, we're going to have to ask Providence to present at the next meeting, and I think we have time for Moda to go.
Okay, so Moda, let's key you up. Welcome.
Good afternoon. I'm going to wait for my team to show their faces here, and then we'll get started right away. Great. And Karis, do you want to start us off?
Yes.
Great, thank you.
Welcome. Good morning, everybody. I'm Karis Stoudemire-Phillips, MODA Vice President of DEI, Diversity, Equity, and Inclusion, and Community Initiatives. MODA's commitment to diversity, equity, and inclusion runs deep. Simply stated, it's a part of our DNA. It's who we are and who we always will be. MODA is not only a health insurer. We see ourselves and desire to be viewed as a health partner. Your members are more than just MODA members to us, and we want to partner with each on a journey to overall better health. A part of the journey to better health includes the recognition that everyone's health journey is different, and that race, ethnicity, heredity, social impacts, and more affect health outcomes. I think we've heard a lot about that today, and we can definitely test that that is true. In 2016, we established MODA's Diversity Council. As a founding member of MODA's Diversity Council, myself and colleagues committed to actively dedicating our time to formalize how we at MODA celebrate diversity and create an inclusive workplace. The council, both then and now, is composed of MODA employees from every level, top down, bottom up, meeting in the middle, with each possessing an equal seat at the table as a contributor to our collective advancement and success. The committee is focused on health equity, language access, marketing, vendor DEI, recruitment and retention, training, and business development. We further expanded and deepened our commitment to our focus on DEI and in 2019 with the creation of our board DEI committee. The committee's charge is to assist the board in fulfilling its oversight responsibilities with respect to the company's goal to support our current and future employees by providing an environment which promotes diversity and fairness and which offers an equal opportunity for all employees. I'm extremely proud to tell you that we recently, both internally and externally, shared our vision and dedication to DEI with a declaration. It reads, "Here at MODA, we're committed to making healthcare work better for everyone." We realize that truly standing by this commitment means understanding that this goal isn't one of equality, it's one of equity. It means truly seeing our members, hearing their unique needs, and acknowledging that those unique needs are often directly tied to systemic disparities that exist in not only the communities we serve, but also throughout our entire country. And paramount to being empowered with this knowledge, it means doing everything we can to understand how to participate in building a more just society. Social injustices have served as a reminder of how crucial it is for these elements to be measured in doing right by our employees and communities. Crises that disproportionately affect communities of color and other marginalized groups continue to leave us feeling helpless at times. But at our core, we believe that with a new day comes the opportunity to be better, to work harder and faster to create measurable change. Through this lens, continuing to establish equity within our own walls is crucial, by not just building a more diverse workforce, but also by supporting that workforce through inclusion, education, and opportunity, and by creating spaces that allow for crucial conversations and transparency at all levels. We fully embrace these efforts that will better equip us to support our communities. We know these goals will not be achieved overnight, but they are achievable, and we are committed. We will be better, we will do better. It is the right thing to do, and we expect it of ourselves. We are proud of our declaration. It is strong, and it is impactful, and it is relevant to MODA, reflecting our business, our commitment, and our firm stance on our direction. It is not enough to simply state that we believe in and support equality. Equality means the state of being equal, especially in status, rights, and opportunities. That's just not enough. We must strive to attain equity, the quality of being fair and impartial. As we state, our members have unique needs, and we will be both fair and impartial in serving those needs through a lens of understanding. Now, please give your attention to my colleague, Dan Toma, who will share about our behavioral health provider diversity. Thank you.
You're on mute, Dan. Thank you.
All right, thanks, Karis. If we can advance to 2 slides forward. Thank you. I'm Dan Toma, Senior Manager of our Behavioral Health Program. And within our Behavioral Health Program, we have for quite some time tracked both demographic data on our providers as well as areas of clinical expertise. And so we are able to, and we store that in our internal database, so we're able to identify providers of various ethnic backgrounds, providers who speak different languages, providers who identify as LGBTQ+. And we're actually also able to track intersectionality among those. And so we keep list, for example, providers who are African American and LGBTQ identified or LGBTQ friendly. We keep track of providers who have identified competence in doing evaluations for gender-affirming surgery. And so we're able to match members up with providers of those backgrounds and with those specialties. We do have issues with our data collection, so I'm going to give you some numbers, and the numbers are not entirely reliable for a few reasons, which I'll go into. But one of the issues with those is the method that we've collected data historically hasn't clearly distinguished between competency and identification. So we may have providers who have indicated African American, and it wasn't entirely clear to us if that's a provider who identifies as African American or identifies as being culturally competent in serving African Americans. So we've done some work in filtering out between those things, and we've identified basically 83 behavioral health providers within our network who we've been able to verify are of background that's of interest, such as African American, Latino, Latina, Native American, and so forth. And that represents a little over 1% of our panel. We've got a very large panel of 7,000 behavioral health providers. Looking through another lens, using a newer methodology that we're applying to both medical and behavioral health providers that Melissa will be talking to you in more detail about soon. We've got about 16% of the providers who've responded to the survey using this new methodology who are identifying as having one of those backgrounds. So we've got a ways to go in terms of our data collection and verification to really get more precise numbers in terms of the size of the panel with those diverse backgrounds. In addition, you were interested in availability for to see new patients for those providers. Pretty much uniformly, those providers indicate to us that they're available to see new patients. But we know through experience that them indicating to us that they're available to see new patients doesn't necessarily mean that they're actually able to take a new patient at this point in time. And so it's really difficult to identify at any given point in time the proportion of those providers that are actually available at this time for new patients. One of the things, particularly with behavioral health providers and with smaller, because the network is fragmented with a lot of individual practitioners, they may be available one week and not available the next week. And so it's just very, very challenging to track that on an ongoing basis. And so that's really more of an ad hoc exercise. If we can go to the next slide. So you're also interested in how we actually assist our members when they have this need. And this is something that we feel really proud of and very confident in the work that we do. So if a member contacts us requesting a provider to meet their needs, the first thing we'll do, if they don't have a particular provider in mind already, we will do that provider search for them. We can also make those calls out to verify availability for new providers. And this is actually true on the medical as well as the behavioral health side. Behavioral health side, we're able to consult our internal database as well as various external sites that are out there that we can use to do that investigation. On the medical side, because we don't have those data, we don't have very much of that data at this point, more doing phone calls out, looking at provider websites and so forth to identify those providers that match the member's background. Another thing that we'll do, sometimes members will call us because they've already identified a provider and maybe they've had difficulty, finding an in-network provider that matches their background. If they've got somebody in particular in mind and we're not able to match them up at that particular time with somebody who matches their background, that's a reason that we'll do a benefit exception, and we will allow the in-network of benefits for that member to see that provider. In addition to that, our process at that point is to do all that we can to recruit that provider into our network so that future members who are interested in seeing that provider don't have to go through that benefit exception process. So also with Moda 360 as a new service that we've stood up within the past year, that also has provided us an additional resource for the health navigators, really to go that extra mile for members who are looking for a particular kind of provider, who are looking for providers with particular background and expertise. And so we're able to draw on that resource to help with those provider searches as well. And at this point, I would like to hand the baton to Melissa Strong, who's our manager of provider strategy, and she will talk more broadly about our strategy for in terms of our overall network development.
All right, thank you, Dan. So if we could go to the next slide. I'm going to go a little further into the initiative that we began implementing this year to increase the provider data that is available to our members and how we plan to improve on the care that is available to our members as well. So provider diversity data has been available for our behavioral health providers. However, we did not have that same data available for our other provider types. And we are now collecting this data for all providers. So primary care, specialty care, all of that is medical providers as well. So our phase 1 included creating more space in our provider data systems to track more practitioner and clinic specific information, which does translate to what is displayed in our online provider directory or Find Care, which helps to provide our members with more information to help them find a provider that meets their specific needs. So in our next slide, we will go into some more detail on what these additional data points are. But our goal to have these data fields to display in our online directory was July 1st, 2021, which we were able to achieve. So that was a very exciting moment for Moda Health. If we could go back to the previous slide still. Our phase 2 of this project represents our efforts to collect the additional practitioner and clinic specific data that we will mention shortly. So we began these efforts in May of this year, reaching to every medical and behavioral health provider in our network, inviting them to complete an electronic survey at the practitioner and clinic level. For larger clinics and health systems, we are willing to work with them on different methods of sharing this information because we do understand that an electronic survey for each practitioner may not be feasible. One thing that is really important to mention is that this will be an ongoing effort where we continue to remind our providers of the importance of sharing this additional information and how that translates to better care for our members and their patients. This really is going to help us determine what our baseline is for what our provider makeup is and where we can continue to make improvements and bring additional providers into the network. Okay, I see a hand up. So is there a question?
Yeah, as part of the expanding the network and increasing provider diversity, is increasing provider compensation part of the mix?
Yes, so kind of this phase 2 that I mentioned where we're trying to really understand what the baseline of our network is, because this is historically not information that our providers have shared with us. So we really need to understand, what is the racial and ethnic makeup of our provider network. And then once we have a better understanding of what that is, we can then analyze where we need to make improvements and where we may need to add additional providers into our network. That's not to say that we don't do things today to try and improve upon that. So when we are notified of providers of color or providers that provide specific services for our culturally diverse membership, want to join our provider panel, we will prioritize those requests and bring them in network. So next slide. So these are examples of the additional data points that not only we are asking providers to share with us, but also information that is now available to display on our online provider directory. So this would include race, ethnicity, languages spoken for providers and clinic staff, if cultural competency training was completed within the last 12 months by practitioners and clinic staff, detailed ADA accessibility at each brick and mortar, translation and interpretation services that are available, specialized clinic services, gender and gender identity, specialized medical, behavioral, and dental health expertise and services, as well as telehealth and other specialized settings for care. Okay, next slide. Okay, so we are seeking diverse providers that represent communities of color and the LGBTQIA+ community, as well as focusing on using community partnerships for guidance, which we will have examples of. Our goal is really to expand on the provider types that we include in our commercial networks, such as traditional health workers, although we do already incorporate behavioral health peer support specialists. But beyond including these new provider types, we will implement projects to address potential billing issues among any other challenges to attract these providers and ensure that they have a smooth transition to our commercial networks, as it's very likely that these traditional healthcare workers or other types of providers do not have a history with working with health insurance carriers. So we want to make that transition as smooth as possible for them. Okay, and then moving into the next slide. This does show different examples of community providers that we are outreaching to and hoping to partner with to expand our provider presence. So this includes culturally specific community healthcare organizations such as Asian Health and Service Center, North by Northeast Community Health Center, Virginia Garcia Memorial Health Foundation, as well as nonprofit organization partners such as Adelante Mujeres, Apano, Cascade AIDS Projects, among some others that are listed here. So essentially, we're hoping to partner with organizations that can help guide us in what is important to our diverse member population and help us identify what types of providers or community figures we should include in our networks to provide greater care for our members. Okay, and if there are no questions, I'm going to pass it on to Erica. Well, she will begin talking about digital point solutions.
Great, thank you, Melissa.
Yes.
Can I just ask one question?
Yes. Yeah.
Sorry. I just want, where you said that you're reaching out to those different folks on that other slide, has it been pretty receptive, or is this such a beginning that you don't, thank you, will you respond?
I can jump in.
Oh, go ahead, Karis.
Sure, I can jump in on that. So with the nonprofit partners that we've been reaching out to, it has been beneficial and prosperous for us to do that. They are reaching back out and sharing with us ideas on how to connect with more providers, and also giving us names of some providers that we can reach out to directly.
Good, thank you.
Great, thanks, Karis. And thank you, Melissa. So I'm going to talk really quick about some digital solutions that we've brought and made available to our Pebb membership. So as a part of Moto 360, we've been adding some digital point solutions and making those additional providers and benefits available to our Pebb members. And it's allowing them to have access to more providers and access to the care that they need at the right time, because these digital point solutions often have provider networks throughout the whole country. It's just giving and allowing for access to more and different types of providers. So one of the first digital solution that I'll talk about is Maru Health. And Maru is an online 12-week program that addresses anxiety, depression, and burnout. And Maru does have a provider network across the country, and nationwide, about a third of their providers are from a diverse background, but specifically in Oregon, 25% of them identify as a provider of color. And then Maru also has a DEI strategy. So when they're initially looking at providers, they screen those candidates for cultural competency and cultural humility awareness. And then they also provide to their providers a minimum of 6 hours of cultural competency training. That's a requirement for their providers. And then they also provide internal training, education, and clinical consultation. And then they also have a staff position that their job is to address diversity, equity, inclusion, and belonging at the across all of Maru. So next slide, please, Rose. And the other digital solution that I wanted to talk to you about is CirrusMD. And this is a text-first telehealth app that provides access to a provider 24/7, and it is also nationwide. So members can download the app, and then they can start a text conversation with the provider anytime they want, and they can come back to that conversation at any time throughout the day, whatever's most convenient for them. And Cirrus will refer members to a provider of color if the member requests that when they start that text. And then all CirrusMD providers complete continuing medical education courses on cultural competency and social determinants of health, and they do that on an annual basis. And so these are just two of the digital health solutions that we've added as part of Moda 360. I know we talked some more that we added for this current plan year, and then also this coming up plan year that's starting here very soon, 1/1. And we're also evaluating other digital point solutions as well as behavioral health digital point solutions as well to offer to Pebb membership. And as we do that and we evaluate those providers, we are looking at what kind of access to providers of color that it provides to our Pebb members. And we're also looking at their strategic approach to DEI. So those are all things that are involved in the conversations that we have around these digital point solutions. And Rose, please to the next slide. And then you can quickly go to the next one too. But we're going to shift the conversation a little bit to social determinants of health. And first, I'm going to talk about, I'm going to give an example and kind of walk through an example of how one way that we address this at MODA. And then I'm going to pass it to John Klaus, who is our Chief Data Officer. And he's going to talk more specifically about MODA 360, what we've done with social determinants of health, what we're doing, and where we're going. But first, I'll talk about the example. And sometimes I think it's easier to understand what we do in just providing an example instead of just some bullet points on a slide. So this example is from our C3 program. And so for Pebb, we offer a program to members, and these are our highest risk members. And we enroll them into the program, and it waives their copay for primary care office visits. And then it also assigns them a direct health advocate. And so in this example, our health advocate had reached out to this Pebb member that we had identified for the program. And as the advocate reached out, it was a mom, and she let the advocate know that actually her dependent needed some advocacy support and asked the advocate if they could reach out to their dependent. And so the advocate did. They contacted the dependent, who was a 23-year-old transgender male, and they were needing help finding new providers. And in that conversation, the member had communicated to the advocate that they felt like their psychiatrist and their PCP weren't really listening to them, and that they also wanted to get set up with a therapist, but they just didn't really know how to do any of that. So the advocate was able to find new providers for the psychiatry and primary care and therapy that were all accepting new patients, and that also work within the LGBTQ community, because we do have access, as Dan explained, to that information about our behavioral health providers. And then the member also expressed that they wanted female-to-male top surgery, and they were able to get that member connected with the OHSU transgender program and also help them submit the referral to get started with the program and just help them start that process and get them going on their way. So that's just an example, one example of how we work with social determinants of health. And as our advocates are working with our members, they're often getting additional information outside of just that clinical patient that we see coming through claims data. So as we get that information from our members, we do put that into our internal systems so that our other MODA staff that are working with these members can see that information. And as you can see in this example, the advocate was able to connect this member to the resources that were needed for them. And in this example, it was resources that are underneath their benefit plan and our provider network. But there are also times that the advocates can connect them to our digital point solutions to programs that we offer at MODA, and then also to programs that we offer in the community. And our advocates are aware of a lot of these resources and are able to connect them. So that's just one example. I'm going to pass it on to John now, who's going to talk about some of the more exciting things we're working on.
Thanks, Erica. Appreciate that. If we go to the next slide, actually, I'd like to deviate a little bit from what I had originally intended to talk about and follow up on one of the subjects that Michael brought up in his introduction, and the social vulnerability index. And so let me kind of frame it in the conversation as the intersection between provider diversity and the diversity of their member panels. And so based on who those providers are treating, we can get a sense for how we might be able to improve engagement or interventions or provide resources to those providers based on the patients in their panel. And it's often the case in healthcare that we know everything about the patient, but nothing about the person. And so that is the origin of the need to bring in social determinants of health into healthcare. And at MODA, under MODA 360, health context is the umbrella we've created to incorporate demographics and identity and social determinants and a number of other factors that are typically looked at as not clinical in nature, but have a huge bearing on health outcomes. If we go into the next slide, we'll dive just a little bit deeper into health context. And here, we're showing the MODA 360 member portal. We've incorporated OHA's race, ethnicity, and language and disability construct and their draft for sexual orientation and gender identity to help us get part of a picture of our member, and at the same time adding in the accountable health communities survey to bring in social determinants of health. And so this is our forum for the health navigators or the Care 360 navigators, the members themselves, to actually help us collect the data that will help to guide those resources and help identify opportunities for them. Actually, what we could do in that context, let's go into the next slide, and we'll talk about how we've been using health context. In the past, we've talked about it as the basis for curating third-party health solutions. So how do we know which diabetes management solution is working best for which segments? Or how do we orchestrate across third-party disease management solutions and primary care and subspecialty? And so health context is the underpinnings of our machine learning, our artificial intelligence to help with that analytics and reporting. But we can also apply it a little bit differently. Actually, if we use the CDC's social vulnerability index, we can take a look at not the provider, but the patients in their panels. And we can look at what those patients live, and we can identify which are living in a census tract that is at a high risk. It could be socioeconomic, it could be a household or a disability issue, it could be a minority status or a language diversity, or it could be housing and transportation, very, very fundamental things. To Michael's point about social determinants affecting members in a commercial population, if we look across, apologies, it's combined OEB and Pebb, there are over 17,000 members who live in a census tract that is in the top 10% for risk in one of those categories. And if we look across our providers, there's about 119 providers. These are providers that are seeing at least 20 OEB and Pebb patients. 119 of them, more than half their practice, is addressing at-risk populations that live in a census tract that are designated as at-risk according to the CDC's Social Vulnerability Index. And we have 45 groups, large provider organizations, whose panels consist of a majority of people who have those risks. So this is how we use health context, not just to look at the provider or the member, but the intersection between them. And it helps us to identify which providers are serving a diverse community or at-risk community and make sure we can guide resources to improve engagement and interventions for that population of members. And very importantly, to support the work of those providers who are often overburdened and overloaded as it is. And so making sure we can see differences not just in the member, but also in the provider with health context.
And I'm sorry, we've run over, and Ali he popped on screen, so I'm sorry. I think that, do I need to end?
No, it's okay. I'm having bandwidth issues, and my camera keeps going in and out.
Oh, okay. I was worried because I'm like trying. This is such good information that I just. Oh, okay. Sorry to interrupt.
John, did you have anything else you wanted to talk about?
No, I'm happy to follow up on anything. In fact, if there's interest, a little deeper dive into the social vulnerability index later. But for today, I think that covers what we wanted to do in terms of bridging health context providers and members.
Yeah, and thank you, John. And I do want to say, I believe that we're coming back in November, and we'll be providing additional information about the work we're doing here.
Thank you. Rose, did we have any public comment?
No public comment, Kimberly.
Thank you so much, Rose. So I just want to thank you all for attending today's Pebb board meeting, and I will be calling this meeting adjourned unless there's any further comments that anybody needs to bring up at this time. Sounds like we're good. All right, you guys take care and be safe, and we'll see you again next month. And Cash, thank you and your team for moving on to next month's meeting. Appreciate that so much.
Thank you.
No problem. Pebb's the boss.
Bye.
Thank you.
Thanks.
Bye.